Welcome to EM Cases Rapid Reviews, where we review the take-home points from the EM Cases main episode podcasts so you can ace your exams and take stellar care of your patients.
Hey folks, I'm Dr. Patrick Gilbride from Emergency Medicine Cases, back for part 2 of the rapid review of podcast 79 on pediatric asthma. In part 1, we reviewed key features in the assessment of asthma severity and the role of investigations in the emergency department. In our second part of this video series, we'll review both the standard treatment and emerging treatment options for pediatric asthma. We'll then move on to highlight the criteria for discharge of these patients and review the important components of discharge instructions that you want to include in your conversations with patients and their caregivers before you let them out of your site in the ED. First up, treatment options. So for the most part, the management of pediatric asthma is really centered on 5 treatments that have some evidence behind them. And it's really essentially the administration of oxygen and the use of an inhaled beta agonist like salbutamol that's kind of at the core of the treatment. You know, once you've assessed your patient and you've made use of a clinical decision tool like the PRAM to augment your assessment of severity, then you really shouldn't delay things. Just strap an oxygen mask on these kids' faces and get the Ventolin going into the patient as quickly as you can. So one question that always comes up is what's the actual best route to get the beta agonists into your patients? And it's actually been demonstrated that compared with nebulized treatments, the use of a meter dose inhaler with a spacer is actually equally effective for children of all ages across a wide range of illness severity. In fact, in the 1 to 4 year old population, using an MDI with a spacer has been associated with a greater reduction in wheezing and a lower overall hospitalization rate. Now, one nice perk with the MDI lies in the fact that nebulization treatment takes about 10 to 20 minutes to administer just one round of treatment, and an MDI takes only 3 to 5 minutes to administer an equivalent treatment. That means we can get about 3 treatments into a patient with the MDI in the time that it takes to get in just one nebulized treatment. Now, I got to temper my optimism for the MDI a little bit by saying that MDI shouldn't be used in patients with impending respiratory failure because these patients may not have tidal volume sufficiently to inhale all the medication within the MDI spacer, and kind of in a similar vein, patients less than 1 year of age have difficulty coordinating their breathing with administration of the inhaler, and in those kind of patients you want to avoid your MDI also. So our third evidence-based medication is ipratropium bromide, which is an anticholinergic medication. And this med has been demonstrated to actually be a good adjunctive treatment with your beta agonist therapy because it's been shown to improve asthma severity scores and decrease your overall hospital admission rate. Now, the benefit we get out of this medication seems to max out after its third co-administration with salbutamol, so this isn't something that we're going to continue throughout their duration of their emergency visit or something that we're going to discharge our patients home on. Next up are the corticosteroids. Now, these meds actually require 2 to 4 hours to provide any benefit at all to the patient, so early administration of these meds is absolutely crucial. The use of steroids has actually been shown to decrease the need for hospitalization and decrease relapse rates, with the greatest improvements being noted in patients who are the most severe. So how are we going to get these medications into our patients? Well, first off, there's actually no evidence that inhaled steroids are beneficial in the ED, so that's off our list. And the preferred route of administration of corticosteroids in the emergency department is actually oral. Recent studies have displayed that a single dose of dexamethasone at 0.3 to 0.6 milligrams per kilogram is equivalent to administration of a 3-day course of prednisolone, and therefore that kind of eliminates the need to discharge these patients with the steroid prescription, and really just kind of eliminates any concerns you might have that that patient may not be compliant with their systemic steroids once they've been discharged. Alright, the last of our Fab 5 core medications is a smooth muscle relaxant magnesium sulfate. Now, although there's not as much evidence for the use of MAG as there is for, say, oxygen, beta agonists, anticholinergics, and steroids, it actually has been shown to help with bronchodilation, and it's been associated with an overall improvement in respiratory function and a decrease in hospital admissions. You want to consider the use of magnesium in patients who present with a moderate to severe kind of exacerbation who aren't improving despite their initial 3 treatments of the beta agonist and the anticholinergic. Don't be scared to pull the trigger early on administering MAG though. Give it early because that's actually where studies have shown that it derives its most benefit. Now for the treatments with varying levels of evidence like Heliox, ketamine, and administration of oxygen with BiPAP and high-flow nasal cannula. The majority of experts would actually suggest limiting the use of Heliox to just the ICU setting, and although ketamine, BiPAP, and high-flow nasal cannula have not been actually shown to decrease the need for intubation, for the most part they're generally considered safe, and they're actually an option in patients that maybe you've maxed out your other standard treatments for. So long story short, don't reach for these initially, but keep them in your back pocket in case you're kind of getting stuck waiting for your backup from the PICU to arrive. Now, the last piece of our management puzzle is our decision regarding the disposition of these little asthmatics. In terms of generally accepted discharge considerations, kind of the current minimally accepted criteria for discharge are patients that after 4 to 8 hours of treatment in the emergency room have 1. Demonstrated improved air entry, Number 2 are requiring the use of beta agonist therapy less than every 4 hours. Number 3 are maintaining a room air oxygen saturation of at least 94%. And lastly, demonstrate no to minimal signs of any respiratory distress. So let's say your little patient has actually met those criteria and you've made the decision to discharge your patient. Now it's critical that you physically provide detailed discharge instructions to the patient and their caregiver in the form of an asthma action plan. Now this has actually got to be a physical document that you hand to the patients, and they can actually carry it away with them and they can refer back to it after they've been discharged. The information in the action plan should actually provide a sense of the duration of the illness and clearly outline any signs and symptoms that indicate a need to return to the ED. It's also important that patients are discharged with an actual working understanding of how to actually use their MDI and their spacer. There'd be nothing worse than to send them out the door and they don't know how to use this thing once they get home. You can simply make them administer a treatment in the ED to prove this, and so that you feel confident that they know what they're doing. Then you also want to provide them with instructions to continue the use of salbutamol every 4 hours until the exacerbation resolves. In addition to the salbutamol, they should also be provided a prescription for an inhaled steroid to be taken for at least 3 to 4 weeks or until they see their primary care provider or an asthma clinic. I mean, it's important that you're judicious, though, when you're dosing your inhaled steroid, because total daily doses of fluticasone greater than 200 micrograms in the pediatric population have actually been associated with cases of adrenal suppression and shock. Now, all of this information has got to be included in the written asthma action plan, and that's got to actually be provided to the patient prior to the departure, as well as they need to have a clear plan for follow-up with their primary care clinician or a local asthma clinic. Well, that's part 2 of our rapid review of pediatric asthma management in the emergency department. The key take-home points for this part of our rapid review would be 1. Be aggressive and initiate treatments early when managing these patients and make use of frequent clinical reassessments to ensure that you're actually optimizing treatment. 2. Before you send somebody out the door to go home, make sure you mentally run through all those key discharge criteria in your head. And then thirdly, ensure you provide an asthma action plan to all discharged patients. Good luck on your next shift, and I hope you get a chance to implement some of these points from the rapid review when you're seeing your next pediatric asthmatic. For references and a written summary on pediatric asthma, go to the Emergency Medicine Cases Summary for episode 79 at emergencymedicinecases.com.